Thanks very much for the kind introduction, and thanks very much to Teresa as well for the kind words in what we've been able to achieve as a network, as a partnership of many different people on the island of Ireland and colleagues from the UK. I'm going to give you a couple of stories about trials and systematic reviews and the impact that they have had, and hopefully that they will continue to have, to try and give you some feel for what it is we're all about as we're doing trials and reviews. So I've worked on trials, been fortunate to work on trials and systematic reviews for quite a while now, with several of the people who are going to be speaking later today and who are going to be doing workshops tomorrow. So why do we bother? Why do we actually bother going to the trouble of doing these trials and then doing reviews of them? I mean, is it just an academic exercise? It's nice to receive funding from the HRB, it keeps us in jobs, it keeps our institutions ticking over. But why do we actually bother? We're all consumers, providers, payers, or carers. I'm not a practitioner. I'm a researcher, and my job is to do research that helps practitioners and patients make good decisions. And we are all those things. And whether or not we're providing healthcare as practitioners, as professionals, or we're providing healthcare for our children or our parents or our friends, we're all doing these things. And whether or not we're payers because we're in Boots the chemist deciding what to buy, or we're payers because we're paying taxes into the health system, or we're payers because we're paying into insurance schemes, and we're all carers. Direct carers, but also we're human beings and we care about other human beings. We hope that what we take as medicines, or what we take as advice, or what we do as in exercise, or what we are given as medicines, or what we're given by a surgeon in terms of a surgical operation, what we're given by a speech therapist, what we're given if we're in a nursing home, and what we give will do more good than harm. And we need reliable, robust, trustworthy information from the past to help us make good choices about the present and the future. We're having to rely on the information from the past. So we need research that will answer the fundamental question, what's likely to happen if I have or I don't have the intervention? Whatever that intervention is, whether it's a tablet, whether it's a particular type of surgery, whether or not it's physiotherapy, whether or not it's a change of diet, whatever it is, we want an answer to the question, what will happen if I do it or if I don't do it? And we're going to have to try and answer that by what is likely to happen. We just don't have the wonder stuff out there, which we can guarantee is going to be beneficial, or we know for sure will be useless. Sometimes it might work, sometimes it might not. We're dealing in averages. So it's what is likely to happen? What's my best bet? So I'm going to take you on a journey. I'm going to take you on a journey again. Some of you will be familiar with this journey. You'll have seen me talk about it before. This is an area that I work in still with colleagues in Oxford in a big review, and I'll come back to another story from this review later. So it's a question about the treatment of women with breast cancer. And it's a question about a particular treatment, which is ovarian ablation. Ovarian ablation is the removal of a woman's ovaries or stopping them from functioning, with the idea being that breast cancer cells are breast cells. They will be stimulated by a woman's estrogen. If the estrogen sources were reduced or removed, would that make a difference if, after having had surgery for her breast cancer, there were still some breast cancer cells around? So that's the question, that's the topic. So I'm going to take you on an evidence journey, and I want you to be thinking about, when would you step off this evidence journey? When would you say, stop the bus, I want to get off, enough is enough, I have the evidence, I can now make a decision. And I'm going to show you how this journey evolved over time, and just think, when would enough be enough for you? And there isn't necessarily a single answer here. And it's the job of people like me to try and generate the evidence that gives as many people as possible a sufficient answer for them. So we begin, 1889. A German journal, Schislinger, writes that ovarian ablation might be beneficial for women with breast cancer. And I've sort of done the preamble on that. We've got a bit of biological theory for it. Do you get off the journey now? In the 19th century, the German literature is the prestige literature of medicine. That's where you would publish. Now we're all chasing down, Lancet, New England Journal of Medicine, maybe Nature if we get lucky. I mean, maybe do we all have a Nature paper inside us? Probably not. I'm afraid I don't think. But 19th century, that's where you'd publish your good stuff. So what do you think? Do you get off now? Why don't you get off now? It sounds like a good idea. There's a good biological rationale behind that. I can't read German. If I could read German, I could say more than lift one quote, lift one little sentence out of this article. Why don't you get off it now? And I'm going to try, I want you thinking, and I want you speaking. Why? Why don't you get off when a prestigious journal publishes a paper saying this might work? Why is that not enough? It says might. Okay, so it's linguistically, you are looking at it and saying might. If Schislinger had said ovarian ablation will,
and then you ask them, why do you say that?
Why do you say that? And you'd explore the evidence. And if he said, I'll say it because I'm right, I'm saying it because of the biology. So again, you're thinking about the words, you're cautious about might. And the awkward thing, if you say no, I want to stay on the bus because it says might, sadly, look at most of the healthcare research that we've done, even what we would regard as the definitive research, and most of it's going to end with, this might be helpful. Because we cannot guarantee it. We just can't guarantee it. We don't have those really great targeted therapies. And again, maybe when we do this conference in 10 years' time and we talk about genetics and so on, and maybe we've got more targeted therapies. Most of the diseases, I don't think, in my lifetime, we're going to see some of the targeted therapies for all of the really common diseases. They're too messy, they're too complex. So it's a might, and we'll still conclude many things with might. So let's move on. What do you do after you've had an idea? What would you do? What would you think, okay, what should Schislinger or someone else go on and do now? Good idea. What do you do? What's the first step on the generation of knowledge after someone has an idea? You see what else has been done. A classic, a beautiful answer, and if I'm just looking around to see if Ian's here yet. Ian's not here yet, I don't think. People like Ian and myself will argue very strongly, no new research without a review of what's gone before. So it's a fantastic answer. Sadly, in the 19th century, nothing had gone before that we're aware of in the literature. So what do you do? So you look and see, is there anything out there? What do you do? What else are you going to do? I mean, many of you are experimentalists, I'm sure. Not necessarily that you work in a lab, but if you're like me, you don't read the manual, or you're wondering how to search PubMed, you don't read the manual. You just type a star and see what happens. Oh, it's the wild card, I've cracked it. See what happens if you put and in capitals. So what do you do when you've got an idea? You test it, you do it, you try it. So you do, and again, on the structure of healthcare research, case report. So 1896, now we're into we've now got an article from the Lancet. 1896 is the first case report we've been able to identify in the literature. 33-year-old woman with advanced breast cancer, very large tumour, referred to the Glasgow Cancer Hospital in Scotland. George Beatson removes her ovaries, reports the case in Edinburgh, and then publishes it in July 1896 in the Lancet. The woman lived for 4 more years. Again, I've truncated the case report. So what do you think now? Is that it? Someone's tried it? The woman got 4 more years? Job done? Off the bus? Why not? What's going through your head now? Absolutely. So that's that red question I had earlier. What would have happened without it? Now, if we had a time machine, we could go back. If we were George Beatson, we could go back 4 years and not remove her ovaries and then, parallel universe, see what happens to her. We can't do that. So we're looking at that and thinking, is that she got 4 more years. Isn't that great? Oh dear, she only got 4 more years. We don't know what she would have got. So we need some sort of comparison, but we also need more than one case. That tells us what happened to that woman. It doesn't tell us what might happen next time. So you move along, and you have the next step, a case series. So 1905, again in the Lancet, case series, reports 99 women, 24 experienced a very marked improvement. How are you feeling? About a quarter of the women had a very marked improvement. Do you want to stop the bus? Do you want to get off the bus? And you might want to get off the bus and say, that's not for us. We're not convinced by this. Let's just stop researching it. Let's not have more HRB funding to do more of this research. It's not good enough. Let's abandon it. Or you might be getting off the bus saying, this is great. Why are we wasting time on research? Let's get some national guidance out there. Do you want to get off the bus? 1905? What's wrong? What's wrong with the words on there? Any other problems? So we've got 99 women. We've got 25 with a very marked improvement. How are you feeling? What happened to the rest? Absolutely. So, did the other 75 women experience some great toxicity or great disadvantage, or did they get a marked improvement? So actually, it's doing really, really well. So first question is, what happened to the others? Anything else? What do you know? What does very marked improvement mean? What do you think? Do you know what it means? Could you explain that to anyone? Again, it's a lifted quote. So we don't know what happened to the others. We don't know whether or not 24 out of 99 is good or bad. You're not sitting in 1905 with knowledge of breast cancer survival statistics. You're not even sure what the outcome is they're talking about. And even if you were sure what the outcome is, it's not reported in a way that you could say, okay, yeah, I'd like that. Or, ooh, I wouldn't like that. So we keep going. And the other thing we don't have, of course, is we don't have a comparison group. We're trying to answer the question, what would have happened without it? So we now have a comparison group, and the world moves on in the early 20th century. I said I'm not a practitioner. One of the things I do have a little background in is as a historian. And late 19th, early 20th century, radiation, X-rays are there. Wow, fantastic. Let's treat everything we can with X-rays. And there's all sorts of stories about what was being treated with X-rays. But one of the things that was done, instead of removing the ovaries, this is, in my language, zapping the ovaries to stop them from functioning. This is not radiotherapy for breast cancer. This is hitting the ovaries with so much radiation that they stop working. So we have a comparison. 47 women receive ovarian irradiation, 50 women don't, so we've now got some comparison going on. And Taylor concludes, irradiation conferred no advantage. What are you thinking? If you were a surgeon, what would you say at this point? It's not surgery. What do those radiation people think they're doing? They're making conclusions about stopping ovarian function with radiation. I want to stop it with my scalpel. So that's the first thing. Anything else? And again, statisticians in the room, what are you thinking when you see 47 versus 50? No, conferred no advantage. Again, those of you who worked on, some of you definitely have worked on Cochrane reviews, and you'll know in the handbook, when you get a non-significant result, what do you not conclude from that? You do not conclude that's evidence of no effect. That's no evidence of an effect. So do you think that there isn't an advantage, or we're not able to detect an advantage? And again, the statisticians in the room hopefully will be looking at that and saying, well, come on, you're always doing these tiny little trials. This is just not big enough. This isn't a trial. This is a straightforward comparison. And also, it's a comparison. It's not a randomized trial. And you might be looking at that and thinking, well, are those women similar? So let's get the numbers up and let's get the surgeons back in. 1953, 60 women ablation by surgery, 44 ovarian irradiation, 576 control women. The effects were more promising for ovarian ablation. And again, we've still got very nice natural language, but it's not quantified. And we don't know whether or not those three groups of women are similar. And inside yourself, what do you think? Do you think they're similar? As I said, I'm not a practitioner, but I don't think these women are going to be similar. Surely somebody was making informed decisions about whether or not the woman would go down the ablation by surgery route or the radiation route or not have either. So I don't think those women are similar. So I'm struggling to work out whether or not the ovarian ablation is causative, or whether or not maybe women who are in the ovarian ablation group were just doing better anyway. Because I'm trying to answer that question. What would have happened without it? So we move on. We hit 1948, and Ian is going to show you lots of really interesting historical examples of trials, and talk about when were the first trials and so on. And 1948 is not the first trial, but it's definitely one of the early trials. Now, it's not one of the earliest trials either, as Ian, I'm going to tell you what Ian's going to show as his specific examples. But trials were fairly sporadic in the 19th and 20th century. So this is one of a few trials from the 1940s. It's randomized, so we're all getting happier now. We're here to sort of celebrate randomized trials and trials methodology research around randomized trials. And that used envelopes. And again, some of you are familiar with envelope randomization. What are you worried about? What would you be worried about with an envelope randomized trial? What do people do with an envelope before they open it if they're not being well behaved? Again, some of you are trialists. What do these naughty people do with these envelopes? Well, they have a little look, they have a little peek. And if you were in a radiotherapy, a radiation department, how easy is it to have a peek inside an envelope? Okay, and again, sometimes I lecture in places and we've still got the white boxes on the wall. Clearly not in a hotel like modern as this one, but if you lecture in some of some of the institutions you work in, you'll still have the X-ray boxes on the wall with very bright lights to put the old X-ray film up on, and the younger ones in the audience won't have a clue what an X-ray film is. It's all digital now. So you might be worried. So we would prefer central randomization. Rådnes and Meyer in Norway in the late 50s. Central telephone randomization. So you can see people are moving, but one of the points I want to illustrate, and I'll show with another example, what a long time it was taking. What a long time it was taking. Into the 1950s before we're seeing robust comparisons. By the 1980s, 3,500 women had been randomized into 13 trials worldwide, and a book was published in 1990. So that's 3,500 women. Of a treatment that is potentially fairly widely applicable, but it's only 3,500 women in 13 trials. And actually, when in 1996 we published one of the reviews, and it's probably the first main review of the question, and this is from the Early Breast Cancer Trialist Collaborative Group, where we collect the participant level data from each of the trials. So this is it in 1996. A nice sort of symmetry there. It's not necessarily the way to get things published in the Lancet is to look back a century and then write to Richard Horton as editor of Live and say, "Dear Richard, I've got a nice centenary piece for you. Please could I have it in the Lancet?" The Lancet have traditionally published these overviews, but 100 years after the first case report, this is published. The 2,100 women instead of the 3,500 is because these are the premenopausal women, the women under 50. Even though you might have thought it would be a bit crazy to try and manage hormones by ovarian ablation in the over 50s or in the postmenopausal women, some of the early trials did that. 2,102 women. How do you feel about this now? What you should be feeling about this now is it's clearly telling you an outcome. It's clearly telling you what you get in the ablation group and what you get in the control group and what the difference is. It's got a little bit of statistics in there. It's not telling you that you should or you should not use ovarian ablation. It's telling you that this is our best estimate of what might happen. Now, whether or not that's enough or not enough is not for people like me who work on this review to tell anybody. It's our job to tell you what the number is. It's our job as trialists to give you and me as decision makers a reliable estimate. It's then your job, in whatever role you have in decision making, to decide what that estimate means and whether it's enough whether it's worthwhile. And your job to be thinking, as was said in relation to the 75 women who did not experience a very marked improvement, what happened to the ones who didn't benefit? What happened to the ones who aren't in that group that benefited? So, put these up fairly quickly. Evidence-based healthcare, it's not all about randomized trials. That 6% comes from a review of the randomized trials, and we know you've got to think about many other things as well. But we know we want that number. We want to know how effective it is. Is it effective? Is it harmful? If it's effective, how effective is it? Can you tell me who it's most beneficial for? We need to answer the question, what would have happened anyway? We need trials and reviews to help patients, practitioners, policymakers, and the public distinguish between things that work and don't work. And informed choices. So I'm going to show you two examples. Subarachnoid hemorrhage. Who wants to have a go at telling me what a subarachnoid hemorrhage is? Or not telling me what it is, but telling other people in the room who don't necessarily know what it is. What is a subarachnoid hemorrhage? And if I look around this room and I see people who are clinical in this room and they can't tell me what a subarachnoid hemorrhage is, then I'm a little bit worried. What is it? Is it something to do with a spider?
It's a bleed over the surface of the brain.
Thank you very much. Okay, a good or bad thing?
Pretty bad.
A pretty bad thing, a thing we would like to stop. And it's a bleed, and again, a very simple way to imagine it is it's a weak spot on the surface of a blood vessel around the edge of the brain. That weak spot bursts, and we want to stop it from, but it might clot, it might sort of close itself up again, but it potentially is going to burst again, and we don't want that. And the patient is not going to bleed out. This is not going to be a traumatic hemorrhage. The patient is going to die because it's going to damage the brain. So we want to stop it from happening again. Now, imagine that under this big new building, there was a water pipe, and it had a weak spot on the surface of that pipe, and that weak spot had burst. But fortunately, it's very, very cold. So it's frozen. The water came out, but it froze. As soon as it hit the soil, it froze. But you're worried that come springtime, it's going to thaw. So what do you do? How do you stop when springtime comes along? When that ice thaws, then the water's going to come gushing out. So what would you do if there was a pipe under this building? How would you fix it? First thing you could do is you could just clamp the pipe. But you really don't want to be clamping a blood vessel that's feeding the surface of the brain. It's got, that blood's got to go somewhere. Okay. So other things you could do is maybe you could dig a hole and go down and fix the burst. Or maybe you could put something into the pipe and fix it from inside. Now, if we were plumbers, we'd be thinking along those lines. We were construction people. But basically, those are the ways you could fix this on this tiny little blood vessel on the surface of the brain. Go in from outside, dig a hole, lift up the skull, get in, go down, and you clamp it. And you're not clamping the vessel. You're clamping the weak spot. You're clamping the burst. So you're shutting that off, then the blood's going to go fine. Or you go in from inside, and you leave little platinum coils inside the burst bit, and they will block it. So there's a trial called the ISAT trial. And there are many things that are fantastic, I would say, about the ISAT trial. The ISAT trial was led by two jobbing clinicians in Oxford. Andy Molyneux, who's a neuroradiologist, so he does the going from inside, and Richard Kerr, who's a neurosurgeon, so he's the digging the hole, going in from outside. They'd never done a trial before. But they were persuaded that they should do a trial, and they recruited 2,000 people across the world. And they were randomized. It wasn't based on, you look suitable for coiling, I'll coil. You look suitable for clipping, I'll clip. It was you look suitable for both, I'll flip a coin. Now, of course, they were not standing there flipping a coin. Imagine you'd gone in with this traumatic event. You were in an emergency room, and a neurosurgeon comes along and says, do you know, I'm not really sure what to do about you, but hang on a minute, I've got a €2 coin here. Call. Okay. But they randomized. Is it worthwhile? This is the 7-year follow-up graph on death from ISAT. The traditional explanation of subarachnoid hemorrhage to a patient would be a third won't get to hospital. Sadly, a third are going to die before the ambulance can get them or get them to hospital. A third are going to die in the coming days. It's going to go again, it'll bleed again, and it's going to sadly kill them. And maybe a third are going to get through this and come back and be okay. So you can see that that's the death. 6% of the patients who had got as far as hospital and has got as far as being recruited into ISAC, they still sadly died in both groups. But then as you follow them up, you see that the deaths in the neurosurgery group are a few percent ahead of the deaths in the endovascular group. And the primary outcome was dead or dependent at 1 year, and it went from about a third in the neurosurgery group down to about 24% in the endovascular group. And there's another graph. So this is a graph based on NHS usage of coils. In 1990, no coils were used. Why? No one with a subarachnoid hemorrhage in the UK in 1990 got a coil. Why? Why do you think? Notice no evidence, it's no coils, they weren't there, okay? By 2007, more than 3/4 are receiving a coil, and it is almost certainly ISAC, the trial that's driven that. There's nothing else. And also the coil manufacturers were fantastic advocates going around selling the coils. You've got to bear in mind, first of all, any neurosurgeons in the room? How confident are neurosurgeons about what they do? Okay, they're not the meek and mildest of our clinical colleagues. Okay, so they have moved because of this, and it's a sad, sort of there's many elements of this story. And one of the sad elements I feel is that for a short time, the neuroradiologists were the treaters of this life-threatening condition. So instead of being the people that would take the photographs of what was going on inside your head so the surgeons would know what to do, they were the treaters. And what did neurosurgeons think about that, do you think? Okay, and I won't ask, but you can all picture the country where I'm thinking of now, and it's not a European country. What did neurosurgeons in that country, on the other side of the Atlantic, think? They didn't like it either. So they didn't like ISAC. But then what did those neurosurgeons do, and why is it sad for neuroradiologists? And why do we know that they were convinced by ISAC? What did those neurosurgeons do? Trained. They went back to school, they learned to become coilers. So they now, many neurosurgeons in some parts of the world now do the coiling. So quite sad window of opportunity for the neuroradiologists. This is a slide from Charles Warlow, and this just shows what you can achieve with trials. So these are many different interventions for stroke, and some of you, again, who are clinicians will recognize some of those. The bottom line is coiling. The bottom line, the red bit, is when do we have a suggestion? The yellow bit, orange bit, however you're seeing it, is when do we test it? And the green bit is when does it get into practice? Because of ISAC, because of two jobbing clinicians saying we're going to test this and we're going to get our jobbing colleagues on board as well, and we're going to recruit these patients, and these patients are going to be given reliable information, and they're going to agree to join this trial. That journey is tiny. So I've illustrated with ablation, I've illustrated with this. I'm going to go finish with another example from the breast cancer overview of a drug called Tamoxifen. Again, some of you will be familiar with this drug. And it's the concept, again, there's a biological rationale for this drug. Does it work? 30 years of research. At the time that the slides illustrate, it's 30 years of research. 88% of the worldwide data is included in this, and we might think, well, they're missing 12%. What could that 12% do? We know that that 12% could not have a big impact. That 12% is from more recent trials, and I'm going to talk to you about 10 and 15-year follow-up. And it's not really going to have much of an impact, and it would have to be so outstandingly different to the 88%. To really change any of the inferences from this. 56 randomized trials at the time. These are data really from the 1990s, early 2000s. At the time, the most studied drug in cancer. In terms of researchers saying, yeah, let's do a trial of that. And again, raising issues about coordination of research, again, which something like the TMRN will help with. 48,000 women, 18,000 of whom had died. And there's one of the busiest forest plots that you might see. And again, as you're familiar with reviews, with Cochrane reviews and so on. And basically this forest plot is on the left-hand side, it's the cancer coming back, recurrence. On the right-hand side, it's mortality. And every line is a trial. And the three big chunks are 1 year of this drug, so it's 1 or 2 tablets a day for 1 year, middle chunk for 2 years, bottom chunk for about 5 years. And each of the trials has its traditional way of showing these forest plots, a black square, a confidence interval, and if the confidence interval for the trial crosses the solid vertical line, which is the line of no difference, the trial on its own is not statistically significant. Its result is compatible with nothing going on for tamoxifen. It's only when you pool them do you get the little smudges, the little, sometimes called diamonds, and there's an average for 1 year, an average for 2 years, an average for 5 years, and an overall average. And those little smudges are the estimate of effect, combining the studies. And they're nowhere near the solid vertical line. They are nowhere near, oh, it might be due to chance, unless we're going to reject the medical statistical findings when it's a sort of 1 in a billion. Of course, things can happen by chance. Someone will win the lotto. It's chance who wins the lotto. But we've got to think, what does this mean? So I'll skip that one. How sure are we? This bottom section here is the 5-year tamoxifen evidence, and that's the routine way of administering this drug now for 5 years. And that's how sure we are. Statistically, we're very sure. And these are randomized trials. We can't say, well, of course you selected which women would or would not get their tamoxifen. And then this graph's very important, because I'm just going to focus on the right one, and this is from 2005. And it's important because we don't have these wonder drugs. 15-year follow-up. 2/3 of the women in the control group didn't need tamoxifen to get to 15 years. We know that because they got there and they didn't get any tamoxifen. 1/4 of the women got tamoxifen and didn't get to 15 years free of their breast cancer. What we're interested in is that group in between, that 9%, that 1 in 11. 11 women receiving 5 years of the drug, 1 more gets to year 15 because of the drug in these studies. And you've got to look at that and think, is it worth it? Well, you decide whether it's worth it, but you've got the 9%. You know it's not nothing, you know it's not tiny, you know it's not massive, you can make a decision. I'll just skip that. So is it worthwhile? This is not down to tamoxifen. This is the breast cancer mortality of the UK and the USA, showing downturns from the 1990s due to many incremental benefits in treatment, many of which have come from randomized trials. There's no epidemiological explanation for this in terms of breast cancer. This is effective treatment, stopping women dying of their breast cancer. So what again, what's it all about? Well, it's all about better evidence, trials answering the question, what would have happened anyway? Better evidence leads to better knowledge and policy. Better knowledge and policy leads to better practice. That's not my job. My job is the top line. Others in the room, your job is generating the knowledge and policy, guidelines people. Other people's jobs is make the guidelines get into practice, and it's a job of the practitioner, and the practitioner includes the patient who is in the office and who's part of the decision-making process, and that's going to lead to better health. That's all our jobs. All of our jobs is getting better health. That's why we're in this business. That's why we're health researchers, why we're not French philosophers. We're not looking at the art history of the 16th century. We're looking at health. And so just to sum up, that's why we bother. We bother because we're trying to improve people's health. Thank you.